the challenge. But it's not going to change the challenge at all. And that's why we're here today, to try to understand where we have to kind of skew our thought process as we go forward.
And the reason that the bacteria, the acid-loving bacteria, flourish is just because of the naturally low pH?
Well, it's not naturally low, but it's an enhanced low pH.
And
so
it's creating a niche that allows the acid-producing plants to do it. So it's a niche thing. They're not really coming out or transforming.
Exactly. It's basically a coral reef kind of situation. You have a basis, and then you continue to build upon it over and over again. It's the same model that I talk with patients about with periodontal disease, which we're talking about in a moment. You start the overall model, and it continues to grow in base on top of that, on top of that, on top of that. And it just keeps getting worse and worse and worse. So that's kind of the concept that we have to look at. I was honored and asked to contribute to this key opinion leader roundtable about current protocols in managing caries susceptibility back in June. You can go to dentistry today, Inside Dentistry online, and look at it. But most of what I did here in a nutshell, we're going to be talking about all day. So we'll be going on. And some of it, again, is going to just make you go, as you go forward. So as you go, continue to just think that maybe this might be a it's kind of a circumstance. Caries risk assessment. Now, we're moving away from the restorative only concept to the non-operative and preventing caries concept. Several years ago, a conference was held at the ADA to talk about, in which they felt that there's a need for an accurate, consistent terminology in recording caries, lesions, severity, activity in our clinical charts. There are two schools of thought. Of course, you've got the regular folks like you and me that says, let's keep it simple. And then you got the others who have a higher cerebral capability and are involved in academia in some capacity or another that said, we need staging of the disease, we need to assess the activity, and we need to provide appropriate care. Now, somewhere between the two is the right spot. But of course, organizations don't take the easy way. They're trying to formulate how we do things. So in 2008, the ADA conducted their Caries Classification Conference, at which John Kuhn, who's the Director of Research at the ADA, said there is a scientific and clinical necessity for the profession to examine this issue. We need to look at the shortcomings of the current classification system that we're going to talk. They're telling us that what we were taught has shortcomings. That really stinks. But it's fact. We were taught what we knew at that point in time. So we need to look at the more complex issues of demineralization, remineralization, extent of the lesion's activity or inactivity, and how we approach the disease management. So there's a basis there that we have to continue to look at as we go forward. So they came up with this system. So they had a big conference, they had all the players were there. They didn't invite me. They knew better. You guys should have. Harvey knows better. And they proposed some concepts that in your homework assignment over the next 6 months, I would like you to try to incorporate in your classification, in your diagnostics. The International Caries what is that again? International Caries Detection and Assessment System, the ICDAS committee, came up with a staging of caries from 0 to 3, in which there's no disease, initial lesion, moderate lesion, and extensive lesion. And it could be in the 4 surfaces of the tooth structure. The bits and fissures on the occlusal surface, the proximal surface, the interproximal as most of us know it, the cervical and smooth surfaces of the tooth, which is the enamel, and then the root surfaces, which is not.